Thank you, everyone. Thank you and welcome to another Hazelhurst medical update. And tonight's topic is on haematology and pathology medical update. My name is Lydia Koenig. I am CPD Program Officer at the Central and Eastern Sydney PHN. With me also working tonight, Susan McCann, who you met at the front, CPD and PGL Program Officer, and also online, Bertha Harvey, who is CPD and Events Manager. As always, I would like to start our evening by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continued connection to land, water and community, and pay respect to elders past, present, and emerging. I also like to extend that respect to Aboriginal colleagues joining us tonight in person and online. I would also like to thank Liberty Pathology, who is a proud sponsor of tonight's Haematology Medical Update event. Please note this webinar is recorded and is live streamed via Zoom. I would like to ask Anna McGlynn, Program Manager, South East Sydney Health Pathways, Population and Community Health, to give us a quick update on health pathways and haematology. Thank you.
Thank you so much. I think I've got the right screen this time. Are you seeing my slides? Yes. Okay. Yes. So thanks for having me, everyone. My name's Anna McGlynn. I'm the Program Manager for South East Sydney. Just giving you a quick update on the program, both Sydney and South East Sydney, and the relevant pathways we have for haematology. So here are the QR codes. If you don't already have access to health pathways, you can also Google them, or the links are there, and Lydia will be sending these slides out afterwards. The Sydney covers all of the Sydney hospitals. South East covers Prince of Wales, St George, Sutherland, St Vincent's, and Sydney Children's. And you can use the same username and password between the two sites. So you can do quick searches really easily in health pathways. Up the top, there's a little search bar. You can type in anything up there, even doctors' names, and they will turn up. On the next screen, it'll just show you the relevant pathways that those words turn up in. So choose the one that's relevant to what you want. Go to expand all if it's a clinical pathway with lots of drop downs, and then you just go Control F to find that word again, and you can scroll up and down between what all the results are. So in terms of haematology pathways on the South East side, we have quite a lot. Jump in and have a look if you're interested. Just so you know, the benefits of using your local site is that you will get all these public services. So if you have a patient that you need to refer off to see a haematology specialist, you will be able to look at all of these and use the drop downs to get the information that you need. You also have all the private as well. So that's the benefit of using your local South East Sydney site. And the same for the clinical information as well. The way the pathways are developed, we have local GPs building these pathways up, and we also check in with all the local specialists across all the hospitals in our area. And the benefit of that is you get very specific information, like I've highlighted down here, about leaving specialised tests, because the specialists will do that in our area. So that is the benefit of using your local pathways. In saying that, if you've got a patient that is going to see a service in the Sydney area, jump on the Sydney pathways. They've got lots of haematology pathways too, and they're all active links, so you can use them if you want. The other thing we have in South East Sydney is GP colleague referrals. So if you would like to nominate yourself for any of these topic areas and you're happy to see patients from other GPs, please let us know and we'll put your name and your service up in there. And we also have pathways under review at the moment. If you have an interest in those areas and you want to tell us ways that the pathways could be improved, please let us know. At the moment, we're looking at the diabetes, cardiology, rheumatology, immunology, infectious diseases, pregnancy, and aged care pathways. Down the bottom of every single pathway, there's a send feedback icon. So if you come across a pathway at any time that you want something changed in, or it doesn't suit your needs, or you want to tell us it's great, please let us know. We'd be very happy to hear from you. And these are the contact details for our team. If you need to get in touch, they're there for you, and we would love to hear from you. And that's all from me. Thank you so much.
All right. Hello, everyone. Thanks for all attending in person and online. So my name's Paul Downe. I'm a haematologist in private practice, mainly based in southern Sydney. in Miranda at Southside Cancer Care Centre at the Icon Cancer Centre over in Revesby. Her patients stay and a day a week in the lab as a pathologist at Lavity Pathology. I just want to briefly introduce our practice if you're not familiar. So this is our group of docs in Miranda at the Southside Cancer Care Centre, mostly medical oncologists. I've been outnumbered. But I just want to bring Dr. Quinn Liu to attention. So she's a haematologist who's joined us recently. She works part-time at St. George Hospital, and I think she's awesome. I'm very happy she's joined our practice, and you have her a day a week in Miranda. The group at Icon in Revesby, radiotherapy as well, and also a colleague. It's not really big enough, so. All right, so that's our crew out there. So just a brief explanation of where we work. So I want to talk about a few common topics. I find often the common mild topics are actually a bit more controversial. If someone's got leukemia, it's kind of straightforward where to send them or what to do. Sometimes it's the milder things that are a bit more controversial. So iron deficiency is everywhere. And it's always a bit of a dilemma what to do. I get a lot of referrals with a view to an iron infusion. This was a recent case. I actually saw this lady last year. She's quite cluey. She works as a radiographer. She was very fatigued and had iron deficiency without anemia, hemoglobin 121. She really couldn't tolerate iron tablets. And so I went with an iron infusion, and I love iron infusions. I reckon they're great. I think they replenish people's iron and more often than not lead to symptom improvement. But at the same time, I'm a bit intimidated by iron infusions. I worry that we're giving a drug to treat a fairly mild condition. And I've been a doctor since 2006, and I've never been sued, thankfully, but I'm always worried if I ever am, it'll be because of an iron infusion, perhaps an allergic reaction. And you really question whether it's necessary. So this lady, we gave FERRINJECT. I tend to give 500 milligrams for the first infusion if they're not anemic. Maybe I'm a bit soft in that regard, but I do worry about dose-related side effects in the mild cases. So she did respond. Her ferritin improved over time. The hemoglobin, although it was normal to start with, it did improve up to 138 at the peak. And then the iron deficiency reoccurred about a year and a bit later, again without anemia, and fatigued, would like another iron infusion. Because she tolerated the first one quite well, I said, let's give you the maximum dose in one sitting of FERRINJECT, 1,000 milligrams, which would have done the job. But then she called and had quite significant side effects, and to the point where she was on the verge of presenting to emergency. And I think at the end, she took anti-inflammatories at home. She had all sorts of muscle aches and pains and feeling generally unwell. But occasionally you'll get these patients that get some side effects. And I guess that's what I mainly worry about with these patients. You're treating something that's maybe mild, generally works well, but I'm a bit intimidated by the side effects. So what are the side effects? The panel on the left is just a snapshot from one of the brochures from Pfizer for FERRINJECT. Hopefully I haven't had it the practices I've worked at, but I think if you talk to dermatologists, they'll tell you they've seen patients that have had skin staining after an iron infusion. One of my colleagues in Royal Adelaide reaction to FERRINJECT, patient was intubated and put in intensive care. It's meant to be quite rare, perhaps 1 in 10,000 level, but it's a bit intimidating when you hear a case of that in real life. Hypophosphatemia is something that's maybe coming up more and more. Some patients we give an iron infusion and they come back feeling unwell, and you do the blood test, the phosphate's 0.3 we've had on a few occasions. And some of these patients do feel generally unwell. The main risk factors for that are patients who are elderly, frail, malnourished. and I've seen it in elderly, frail, malnourished people. We've seen it in malnourished chemo patients. And I've seen it in a few young women now who in retrospect probably have some sort of eating disorder. So on the one hand, I think iron infusions are great, and they, for a lot of young women in particular, I think they can lead to improvement of symptoms and maybe better quality of life. But I'm always a bit, well, I'm always careful to mention all these potentials to them when they come in for an infusion. Iron tablets, I think in everyone, it's good to have a trial of tablets in the first instance. Most people, it'll do the job. I tend to give this printout to patients. I copied this from a Red Cross website just with common form, something like FERRITIN with 60 odd milligrams. I think as a general rule, oral iron first. I mean, that's probably common sense in what everyone does. I have had occasional referrals where they haven't tried tablets and maybe not. Sometimes the patients actually were a bit nervous about intravenous. So I think it's always worth a decent course of orals. I guess if they can't tolerate or they're unresponsive, then to go IV. I think in some older people, the geriatric patients who may be prone to constipation, even a low dose iron infusion can work wonders. People with kidney impairment, a lot of people with malabsorption, we get, seems to be after gastric banding surgery, which I never quite understood because iron's absorbed further into the small bowel, but there must be reduced gastric digestion that leads to malabsorption. The heart failure patients, I'll often give them in the patients that with bone marrow disease, if we've got a patient with CLL and they're starting to become slightly anemic, and I don't know if it's the iron deficiency or the CLL, and we just want to optimize their iron first. And I guess before a major operation, if we want to top them up, then IV would be the way to go. So on the other side of the spectrum with elevated ferritin, this was a case, this chap was 21, came in elevated ferritin, transferrin saturation quite high, classic genotype for hemochromatosis. So we started him on venesections, and 32 venesections to bring his ferritin down to the target range. I think this is the sort of patient that in the olden days without treatment, he would have ended up with severe hemochromatosis by middle age. So certainly worthwhile treating this chap to improve his outlook. In terms of the genetics, there's often a bit of confusion around this, but there's generally two genotypes that are associated with iron overload. So when you've got two, you need two dodgy copies of the gene and one of the C282Y mutation. So if you get a double C282Y, definitely at risk. If you're the compound heterozygote with one of each, you're at risk. The other genotypes are carriers, or if you've got a double H63D, these people are generally not at risk. All of this comes with caveats. Even if you're in the top group, not everyone is destined to have iron overload and excess tissue iron and organ dysfunction. So you could be born as a homozygote and you could live a normal life. So the genotype itself doesn't condemn you to getting hemochromatosis. But having said that, if people do have one of the top two genotypes, we do tend to treat them. Sometimes it's straightforward, like in that young man. Sometimes you'll see a 70-year-old and the ferritin's 500 and they've got the genotype, and you sort of wonder whether they're really going to get iron overload issues in their lifetime, and is it worthwhile treating them? Is it going to improve their lot? I always think if we're treating them with a medication that had toxicities, then we'd probably think twice. But we're treating them with a natural, it's fairly harmless. So we do tend to treat everyone that has a compatible genotype with an elevated ferritin. I think more and more this is becoming debatable. I think when these genetic tests were first discovered, we found that everyone that had severe hemochromatosis, not everyone with the genotype is destined to go bad. And obviously treating someone with a super high ferritin is beneficial in the long term. There is a group of patients in the middle that might have mildly elevated ferritins. Is it going to translate into problems? And I think that's controversial. When you do get pathology reports back, they will say down the bottom, the target range is to keep your ferritin between 50 and 100. And that's the conventional target that we go by. And that will be the target that the Red Cross goes by. But there is a school of thought that maybe just achieving the normal range, maybe just below 300 micrograms per litre is adequate in these patients that have never had really high ferritin levels. And really when your ferritin's over 1,000, that's when you seem to get the risk of tissue complications. So I think there is some controversies. I tend to stick with what's conventional, but especially in the older patients, I do wonder, are we over-treating people? And I think as the years go by, we'll get more information on that. More common is high ferritin due to other causes. Fatty liver or metabolic syndrome in general would be a more common cause. But this was an older chap, quite high ferritin, up at 1,300, and his genetic tests were normal. He was a big guy. You could probably guess it was metabolic syndrome just looking at him. He was a bit worried about it, and I don't always do this in patients, but there is an MRI scan called an MRI ferry scan, basically an MRI of the liver. And there's a company that has a patent on interpretation software that can analyze your MRI images and correlate that with hepatic iron. And they've done studies to compare it to liver biopsy, and they've found quite a good correlation. So I don't know if liver biopsies ever get done much nowadays, certainly not for iron overload. I think there's a 1 in 1,000 or thereabouts mortality from liver biopsy, so maybe it's a bit intimidating to do. I'll occasionally do these MRI ferry scans in a patient with either an unknown cause of elevated ferritin or if it's over 1,000, I'd think about it. So this chap had the scan, and the report back was that his liver iron concentration was normal, giving us reassurance that his elevated ferritin is not because his whole body's overloaded with iron. My understanding of ferritin is that most of it's packed away deep in the cells, packed away in macrophages and other cells, and only a tiny fraction actually circulates in the circulation. So if you just squeeze a little bit out of the cells, it'll all can increase your blood levels quite a lot. I use the analogy with patients that in peak hour, all the cars come out of the garage and clog the roads, causing a traffic jam. If you're just testing the roads, it'll look bad, but it's not a car overload. It's just all just coming out onto the streets at the same time. So, so this chap, there's no point venesecting him. If you did venesect him, you probably would induce iron deficiency and vessel the ferritin down, but it won't actually improve his health. He doesn't have tissue iron overload. He doesn't have whole body iron overload. He's got fatty liver, he's got metabolic disease. He needs to become like a Buddhist monk and lose weight, eat vegetables, stop drinking alcohol, and do all the do, but it may be unrealistic. But to do the best that they can, and that will actually improve their health rather than giving venesection just to fix the number. I often show this picture. So I just Google fatty liver histology and look at the images, and it comes up with similar pictures. So I tell people with this fatty liver that the normal liver tissue is on the top left. I think that would be my liver on the top right, probably have a bit of fatty spaces in it. But the more severe you get, you end up with more fat spaces than there are liver cells. And I tell patients that's why the ultrasound report says that the echogenicity is different. It's a different shade of grey because it's full of fat rather than liver cells. And this is probably what's going on inside. And I don't know if that's motivating. I think for some people it might be motivating. You could probably argue the mirror tells them the same thing or measurements tell you the same thing, but sometimes it hits home a bit more when I explain this to them. Occasionally you'll get an unusual cause of iron overload. So this was a lady of Asian background with quite high ferritin levels, getting up close to 2,000. And her blood count was pretty much normal, but just a slightly reduced MCH. And she had a rare hemoglobinopathy called hemoglobin constant spring, which is an alpha chain variant that leads to quite unstable hemoglobin. So as a consequence of that, these people often absorb, their bodies respond by absorbing more iron through their life. And interestingly, I think her ferritin once upon a time wasn't too bad many years ago, but she probably hit menopause and then it really started accumulating after that. So because this lady had quite a high ferritin and no known causes, she doesn't have metabolic disease, she's very slim, doesn't have liver disease, there's no hepatitis, etc. So we did the MRI scan and it did show that her liver iron concentration was about 4 times what's regarded as the upper limit of normal. There is some debate about how high does it have to be to translate into causing damage, but for me 4 times is enough to treat someone. And because she's got a normal hemoglobin, we were able to venesect her and she tolerated that. And we got it down within the norm in these patients. I try not to do the MRI scan on milder patients. It's not covered by Medicare. It costs $500 or $600 depending on where you go. I tend to do it if I think it's going to change our treatment. Ferritin is an acute phase reaction. It will go up with inflammation. People with active rheumatoid, I'm sure they'll all be up. If you check it in cancer patients, it'll be high. Chronic infections, it'll be high. It's always hard when you get borderline cases. What if well, often at the deficiency end of the spectrum, if your ferritin's 50, but you've got an inflammatory disease, you could still have iron deficiency, even though it's within the normal range. The rough rule of thumb is that with coexisting inflammation, your ferritin might double or triple is the rough rule of thumb. There are wicked inflammatory disorders. There's a thing called a hemophagocytic syndrome where the macrophages are activated and they just dump ferritin into the bloodstream and they get ferritins for tens of thousands or 100,000 in a quick time. And it's obviously not iron overload. You can't invent iron out of nowhere. It's all just released from the intracellular stores. I guess when to refer these folks, and I guess the question I ask is when do I do this scan of the liver for people of suspected unusual cases of iron overload. So these are people with high ferritin, they don't have hemochromatosis on the genetics. They don't obviously have fatty liver or metabolic disease or any other underlying cause. I tend to do it if the ferritin's over 1,000, but another giveaway is the transferrin saturation. In the real overloads, it tends to be 60% plus. So if we go back to the young man with the real hemochromatosis, his saturation's 87%. That's what we always see. Well, not always, but mostly see in the real hemochromatosis, in the real transfusion-related iron overloads. The fatty livers generally don't have elevated ferritin, sometimes slightly, but generally not over 60%. If someone has a ferritin of 600 and it's probably fatty liver, I don't do much more with them. I just tend to have it monitored and I'd only delve further if it goes up above 1,000. So moving to white cells, monoclonal B cell lymphocytosis is interesting because if we take everyone in this room and we do flow cytometry, probably everyone in the room's over 40, aren't we? Anyone younger? I'm 41. So about 5% of people over 40 have a clone of B cells. We don't need special research tests. We all just head down and order flow cytometry. And about up to 5% of people have monoclonal B cell lymphocytosis. You can think of it as pre-CLL. These people in the old days used to be called early CLL, but I think we realized we were overdiagnosing all of these people. So we made a cutoff. If the B cell count's less than 5, we call it MBL. If you're above that, we call it CLL. But in reality, it's a bit of a continuum. So you'll often do tests like this, probably routine checkups. The lymphocyte count goes up to 5.4, and then the next one's 4.5. And you might get a comment from pathology saying this could be investigated with flow cytometry. So then you do it. And on the next test, although the lymphocyte count has come back to normal at 3.6, the flow cytometry reveals that of these 3.6 lymphocytes, 2.0 are B cells, which is much higher than usual. And pretty much all those B cells are the abnormal clone of B cells. So I don't know how I feel about all of this. I worry that we overdiagnose people with these things, generating too much referrals to me, too much worry for some patients. A lot of older folk are happy to shake it off. They've got other health concerns to contend with. Maybe younger people get quite worried about this. It's not wrong to detect it, but it doesn't necessarily lead to any benefit for these patients. So it's always tricky when you get these mild lymphocytosis. Do you do the test or not? I think more and more you'll have patients poring over their own results, pointing to everything that is abnormal. What about this? What about this? So maybe it's becoming unavoidable over time. I think in the old days, the docs looking after people would just note this and maybe not even mention it, and they'd look after their patients, keep an eye on things. But it's maybe in the modern era, it's for better or for worse. Maybe these things get investigated. So if we do flow cytometry on everyone in this room, we'll find one case of this. And what does it mean for that person? Well, statistically, their chance of developing CLL that needs treatment is between 1% and 2% per year. So it's a low risk every year. Over time, they may increase their lymph count. They might even progress to early stage CLL. But from the point we find this, the risk of it going bad and needing treatment in any given year is about 1% or 2%. So it's quite low. And I think most of those cases that progress would have been ultimately picked up in due course. I don't think we're necessarily benefiting anyone by diagnosing this early. But this is somewhat counterintuitive for patients. People mainly think of things like breast cancer, bowel cancer. Of course, you want to diagnose it early. When we do flow cytometry, this is what we see, and it's these cells here. So CD5 is a T cell marker and CD19 is a B cell marker. So these B cells are trying to identify as T cells with both 19 and 5, which is definitely unusual. And it's quite a clump of cells. It's not just 1 or 2 dots that's background noise. It's a definite population of cells. That's what we see in the lab when we detect these things. Most of these cases, the cells have what we call a CLL phenotype. So what does that mean? Well, they're a B cell, they've got CD5 on them, which is abnormal. They've got a few other B cell markers. They don't have other things that might identify them as different cells. So they're not follicular cells, they're not hairy cells. And they have a small amount of kappa light chain on them. So this is what we'd call a textbook CLL type or phenotype or signature, which I feel quite comfortable with because CLL generally mostly behaves predictably. Sometimes you'll get a result back that has, it'll say a non-Hodgkin lymphoma phenotype or some atypical phenotype. And those ones still generally remain indolent, but I don't trust them as much. Sometimes they misbehave and they might turn into a lymphoma. Whereas a CLL, the worst thing that it's going to do is turn into a CLL, which you're going to watch and wait and not do anything. A lymphoma one might turn into a lymphoma on you with lymph nodes deep inside, and I don't trust them as much. So when do you request flow cytometry? Well, you could do it on anyone with persistent lymphocytosis. I guess you could do it on anyone that has lymphadenopathy. But I guess to beware the test, because you might find these things that may or may not be helpful for patients. Look, when to refer, I think the CLL types could probably be monitored locally. I'm always happy to see them, and I often show them similar slides and to explain it. But I don't think that anything will befall the patient if it's a CLL clone. You just monitor them with blood counts. You'll see them clinically. Nothing's going to be missed. The non-CLL ones probably should get referred. When I get non-CLL ones, I always decide, do I do a CT scan, do I not? And I often do feel a bit iffy about it if they're completely clinically well, but sometimes we'll get a baseline CT, and I'm probably less trustful of the non-CLL ones that they might progress to lymphoma in a less predictable manner. So moving on to other white cells, benign, well, mild neutropenias everywhere. I think you can debate a limit of normal of a neutrophil count is 2.0 is generally accepted as the lower limit of normal. There's so many patients out there where their neutrophil count, it might average 2.0, but half the time it's down, it's 1 point something. And then, and it often fluctuates. And some of these patients, if you go back for years or decades, you'll see they've had this pattern for years. And these ones are benign. And I don't worry too much about them. If their red cells are normal, platelets are normal. It is handy to have historical results. Half my job is looking up old results to compare to. We think a lot of these have an autoimmune basis. So there's no serology or other test you can do to prove that. But even if their neutrophils are 1.0, they've still got enough to do the job in terms of their immune function. So I don't think they're at increased risk of infection. And 99.5% of these will never turn into anything. They'll be fine. So the question with neutropenia is when to investigate further. So this one. Yeah, so this was a benign one where well, I think it was a benign one. I guess we haven't followed up for long enough, but I wouldn't worry too much about this one. Neutrophils, the latest 1.8, 1.7. I guess the platelet count's borderline low, but it's been lowish for years. I think after we saw that patient here, understandably they were referred. It looks like it's dropping down, but I checked twice again, normal range, normal range. I think this person's just going to fluctuate around the lower limit of normal. And in this patient, I wouldn't do anything unless it dropped persistently below 1.0 or if their other counts declined. This was a fascinating case. This guy returned from Bali. He actually got referred because he had a pulmonary embolism. And in the ED, his neutrophil count, I think his neutrophil count was 1.2 in the ED. And by the time he saw me, they dropped to 0.6, and it was a bit weird. He felt completely well. and we just watched it and it stayed low. So I said, I better not miss anything. And I actually remember as I was pushing the bone marrow needle in, I was thinking, Paul, are you over servicing people? This guy's so well. Should we just watch it for a bit longer, perhaps? But he had acute promyelocytic leukemia with these interesting cells that look like overlapping circles, and these things called hour rods in these cells. So this is the most curable form of AML, can be the most deadly in the first few weeks if it's untreated. So it's a good one. I'm glad I did that bone marrow. But again, we stick to our rules. It's persistently less than one that deserves a bone marrow. And so when do I worry? Well, I guess that if it's a definite downward trend rather than a fluctuation, if there's other cytopenias present, or if there's macrocytosis present, it can be suggestive of myelodysplasia. If the neutrophil count's below 1.0, that tends to be my cutoff to really recommend a bone marrow. I guess if there's unusual symptoms, sometimes we get patients with some undiagnosed illness, probably rheumatological in nature, but I'll often see them, run them through tests just to exclude things and to reassure. All right, so that was it for the slides I prepared. I was hoping if anyone had questions or queries or wanted to have an argument about anything, it would be awesome. Yes, ma'am.
Hello, I'm Annalise. One of my questions is actually about B12 therapy.
Yes.
We have a lot of older patients who've had B12 injections for 20 or 30 years and say, I must continue my B12 injections. And I actually asked our medical student today to do a bit of a literature review on spray or sublingual treatment, and she actually felt that it was more effective.
Yes.
So why are we still giving B12 injections? Well,
I think historically the B12 measurement, it's this really complicated assay to measure it, and it was quite, had poor reproducibility, especially around the lower end of the normal range. Like you're getting plus or minus 10, 20% on the same sample for these measurements. And then, so that's grey area number one. And then the grey area number two is that most of the B12, I think 80% of the B12 is this inactive form that circulates and does nothing. So only 20% actually works. And the question is whether you're an active deficiency. But in the old days, they didn't have that test. So everyone had mildly low total B12. They were put on injections. And I guess that was the right thing at the time. But nowadays, if those patients had their tests, they would probably have low total B12, but normal active B12. We wouldn't necessarily, or I wouldn't put them on injections. It gets a bit psychological, doesn't it, with the dependence on these things of patients. I tell my patients that if in the unlikely event I become a vegan tomorrow and don't eat any B12, it'll take me 2 or 3 years, is my understanding, before I become deficient. So if you stop your B12 injections, it ain't going to drop down precipitously. And in some patients I get who might have some mild anemia and maybe the active B12 is borderline. Sometimes I say, look, have 3 injections, we'll keep an eye on it. And if it drops low again, we'll think about it. You don't need it every 3 months. So I think there's always maybe a chance to catch these patients if the deficiency reoccurs. And maybe some of them are genuine, maybe some of them are pernicious. But yeah, I think probably there's a lot of, maybe we overtreated people in the past and it's a vitamin injection, so why not? I've had, it was that patient of yours, Paul, we talked with the MDS and the low platelets. He also had B12 deficiency, but his platelet count was bugger all, so we couldn't give him injections. So he had B12 spray, and it seemed to do the trick. But I guess you have to have that probably have it every day, I think, for the dose. But it seems to, I think it's absorbed well and works quite well from the sublingual. I think it's quite readily available too. I remember we asked it for our chemist. I thought it was some exotic thing, and she said, no, we've just got it on the shelf. Yeah. Is it worthwhile weaning those patients off? I guess probably wouldn't. It wouldn't hurt, and if they're getting checked every so often, there'll be a soft landing if their deficiency does reoccur.
With that, so if they've got pernicious anemia, you do the test for that. So if they don't have that, and they do eat meat,
you still got to treat them, don't
why
you?
should they be like B12? Would you be?
Oh yes, so so the question was in patients who have say patients have pernicious, well, you think they have pernicious anemia, they're B12 deficient, but when you do the serology comes back negative. Is that
maybe they're like maybe they've been on these therapies for a long time and just trying to really need it.
Yeah, I think that's reasonable. I mean, I think the serology is not perfect as well. So if they're genuinely deficient, they need replacement regardless of the cause. And I think in the yesteryear, they used to be a lot more academic. They used to do Schilling's tests with the radioactive B12 that they laced with and made you eat it and then measure it getting, I forget, excreted in various ways. And whereas maybe in the modern generation, we're like, well, it's deficient, just replace it and maybe not think too hard about it. I think if they're generally deficient, they're going to need replacement anyway. So it's nice to do the serology, but if it comes back negative, you could still have the disease and maybe the serology. Like I think the parietal cell antibody test, I think it's 70 or 80% sensitive, I think. And the intrinsic factor, I think, is not sensitive, but it's quite specific. You could get a double negative and it doesn't rule out the disease. And from a practical sense, if they're truly deficient, you're going to have to replace them anyway. Some of my patients, if I'm not sure, we maybe through the course of 3 injections and just check it over time. Don't commit to long-term injections. Just check every 3-6 months, and you'll catch it if it drops down again. And then if they're a repeat offender and it drops down, then you sentence them to lifelong B12 every 3 months, perhaps. I would have thought the patients might want to come off the bloody injections if they could, but I guess maybe there's a placebo.
About 10-15 years ago, a lot of sports people were, you always encounter a lot of patients who are into their sports and they're having series of B12 injections prior to an event, a week beforehand, 3 times a week or something. I don't think there's any science behind that, but they were convinced that they had that edge they wanted. So
Yeah.
I don't think there's science.
No, I think if I wanted to boost performance, maybe caffeine pills might be rather than B12. But anyhow,
a question from Sarah Lynn. An 80-year-old man with low active B12 level, possibly due to red meat intake, adequate dairy and chicken and fish, negative IF GPC antibody, treated with 3 months of daily oral B12 and normalisation of active B12 level on repeat. How often would you monitor B12, and would you recommend ongoing daily or intermittent oral supplementation?
Oh, yeah, that's a fair question. I'd probably think about it and make it up on the spot if it was in the clinic. So the question was patient with low active B12 who had negative pernicious anemia serology, had daily oral B12 supplements. Cause was possibly dietary inadequate intake, but not quite clear. B12 is now normalized. How much do you keep on going with? Well, if you could take either approach, I think you could stop the B12, and the worst thing is that it'll drop down again. If you were checking every maybe 3 months, 3 or 4 months initially, I think you would catch it quite easily because you've got that luxury. It's got such a long half-life in the body. It's going to, if it does deplete, it'll happen gradually. What would I do? I guess if his active B12 came up to a really normal, like if it was borderline, you might keep going. If it was up solidly within the normal range, I'd maybe stop and reassess.
question on macrocytosis? This time be all right? Or not?
Yes, yeah, absolutely. Yeah.
Okay. Often with macrocytosis, we do B12 and folic acid, they're normal. And then we tend to think, oh, they're covered drinkers or something of that nature. But over many years, is it that macrocytosis may be an early indicator of bone marrow disease coming later on, and to keep an eye on?
Yeah, so the question was patients that have macrocytosis with normal B12 folate, we don't think they're drinkers. Could it represent the earliest inkling of bone marrow pathology brewing? And it could, and that's always the question, because myelodysplastic syndromes in particular can present with macrocytosis. Often when they're diagnosed, most of them probably will be a bit macrocytic along with anemia and other low counts. But if you trace them back, often just the MCV is the first thing that heralds it. But there's also this concept of, I don't know that it's got a name, but whether you call it senile macrocytosis or whether, sometimes I think if we're 150, we'd all towards the end of that. Like, is there something that's just brewing under the surface? Investigating these people. I think if it's just macrocytosis and their hemoglobin is normal and stable and white cells and platelets are okay, I tend to not worry too much about bone marrow disease. And the thing is, even if you do a bone marrow on these patients, you're not, and even if they are destined to evolve into myelodysplasia, you won't diagnose it. It'll look kind of normal under the microscope, and you'll get an inconclusive, or it'll just be reported as normal. And I've had these patients you actually think they've got MDS, you do a bone marrow, it's inconclusive, because it has to be kind of bloody ugly to be confident it's MDS. If it's just subtle, you're not going to label the diagnosis. So I don't think you miss out by monitoring those patients over time. Sometimes we get sneaking, and people with advanced chronic liver disease, they often have macrocytosis, but yeah, sometimes you trace them back, and maybe that was apparent before the cirrhosis was. But again, what do? You could do an ultrasound of their tummy, and if it's normal, I guess you're going to watch them anyway. I don't know there's too much you would do with these. Like the monoclonal B-cell lymphocyte, if you go to issues and flaws in a certain percent of people, that'll increase as you get older. So if you do bone marrow biopsies, you might find a missing bit of a certain chromosome. Is it pathological? Is it going to be a problem? And it's hard to say. And it's a bit dubious how far you look into things. In leukemias, we've got all these fancy tests looking for various gene mutations, and I can start picking out all these minor defects as well, which will be of undetermined significance in the long term. Maybe it'll grow into something in the long term, but maybe it won't. How much MCV would I accept if it's just the MCV? I mean, probably a 5% margin. So if your normal's 80 to 100, I'd probably ignore it up to 105. What would I do if someone saw me it's 107 and everything else is normal? I don't know. I'd probably talk to them about it. Maybe you could do a bone marrow, but it's unlikely to be fruitful. Maybe if they're a young person, you might do that sort of thing. Do
you do anything like globulin?
They're just barely detectable paraproteins, and I just feel maybe it's not useful for those patients. So I'd certainly routine screening of these things I wouldn't do. Osteoporosis patients, I would argue not to do. I think if you're really worried, you should do a CT skeletal survey looking for lytic, probably not going to be helpful for those people. It might be useful in some circumstances. I think, Phil, you might have sent me a patient that had low total globulins that turned out to have myeloma, but just the total globulins on the liver function panel. I'm pretty sure it was one of yours. And then the EPG was normal, but we did the serum free light chains, which were quite markedly elevated. So sometimes if that was the case, if the total serum globulins were the sign of myeloma or something similar brewing, I probably wouldn't test people with EPGs otherwise, like unless there's a reason to test, like unless they're anemic or they've got some unexplained kidney failure or a high calcium or something that suggests myeloma or liver disease. I think if you start doing that on everyone, and we can set up a good business and just patients, but it won't actually help people. And it just worries them. Most of these are older folk and they're fine. They're why are you wasting my time telling me about I might have a 2% chance per year of getting myeloma? I've got heart disease, I've got all these real problems, and you're telling me this imaginary problem that probably never happened. Most people are cool with that, but I mean, some of them have anxiety disorders and they really get hooked up on it, and they just worry, and I see them to reassure, but I don't know. Maybe it's low value care, to quote something.
Many sections. Where can we send people for that?
Yeah, so this is harder than it should be. So, oh yeah, so the question was, patients have hemochromatosis, where can we get them venesected? And I tend to send them, I try and send them to the Red Cross when I can. Now they keep changing. They used to have an online portal that you could just put them in, but then I think they found it wasn't secure, so they closed it down and went back to paper-based referrals. And they kind of reject half the patients for really pedantic reasons. I had one young guy, he fainted when he was hungover once, and they wouldn't accept him because he was a fainter, and that was ancient history. So sometimes they reject people, but I always try and refer to the Red Cross first. I think anyone can refer. It doesn't have to be from a specialty clinic. As long as they've got on your referral, I think you put the genetics, the ferritin, and they have a suggested frequency for depending on the ferritin level. I guess you can tweak it if you want, or you just go with the standard, and send it off to them, and they will venesect them X number of times, and I guess you see them again and refresh the referral. So I try and do that. Probably half my patients get rejected or for one reason or another. And so we do them in our clinic in Miranda, but it's done as like a day hospital patient. So they really need to be in a health fund to access that. And then they just pay their health fund excess and that's it. There used to be some labs that would, I know Lavity used to do it in Miranda, but Anne retired from collecting. Yeah, once Anne retired, it was stopped, and I think we miss out. And there is a fellow at the Hurstville Collection Centre who still does them. I think they have to meet the usual donor criteria, like certainly no older than 75. I guess maybe that'd be the only criteria they'd have to meet. Yeah, otherwise it'd be the public hospitals, which is maybe a bit, well, I guess it's not where I work, but maybe you'd have to refer to the clinic there that would then arrange the venesections in-house. Yes.
So we started to do them because there's an item number for it. So
Yep.
I had a few patients over 65 that couldn't go to the blood bank and couldn't afford a private fee.
Yep.
So we just do them on site, and our lab Foresight provide the bags.
They give you the bags.
I actually counted 20 mils, which is quite time consuming. It was still easier in an older, frail patient.
Yeah, yeah. I tried doing one myself once when I started out, and I gave up after butchering the poor lady's veins, and I thought I'll leave it to the professionals, the nurses. It is more complex than you think. I think depends on your local hospital. Out in my Western Sydney practice, the Fairfield Ambulatory Care is I don't even think they ask questions over where they live, and they'll just do it. Yeah, around here it's been tricky because Sutherland, well, I think the St George one stopped accepting. I'd never even know who to ask at Sutherland. So I guess, so the question is, yeah, about thrombocytopenia. There's a lot of mild thrombocytopenia. I probably hate mild thrombocytopenia more than any other thing because it's so non-specific, and you can throw every test in the world at these patients and not come up with an answer. And then there's the question, well, how far do you investigate? And probably for a platelet count above 100, I probably wouldn't do too much. Maybe you do B12 folate, maybe a myeloma screen. That's probably about it. Probably keen not to miss the cirrhosis. And I've had a few patients come in and we do all the tests, they're normal, and then 2 years later, they've got cirrhosis that they didn't have when I first met them. So sometimes it's an early sign of that. Probably below 100s when it starts to get more serious and more worthwhile doing tests. Below 50, I think definitely needs the kitchen sink of tests. Between 50 and 100 even, it's a bit of a grey area. Some people hovering platelet counts of 80. Maybe it's been like that for a little while. They feel fine. I'll probably do a few blood tests, but not that much more on those. I'd certainly bone marrow the ones less than 50. There's no scan. It still relies on a normal bone marrow biopsy and a response to treatment. So you're not going to confirm that diagnosis until they really drop low enough to do your bone marrow and to actually start treatment on it. Once there's that nagging thought, this could be an ITP, how are you going to prove it? Well, I guess you're going to take reasonable steps. It's very fruitless. Below 100, I'd probably start doing more extensive blood tests and abdominal ultrasound, make sure that's done. Maybe hepatitis serology, that sort of test. Below 50, I'd definitely push these people to a bone marrow, maybe between 50 and 100, depending on the patient.